got that. And so is degenerative bone disease related to lupus? Is one of...
So if you take someone who is 20 versus 40 versus 60 years old and has absolutely no medical problems at all whatsoever, then you just took x-rays of them at each of those 20-year intervals, you would quite possibly see, let's say of their spine or their hip or their knees, age correlated degenerative changes which are commensurate, which would be expected for that. In the context of lupus, is it fair to say that they're going to have an acceleration in that process? It doesn't have to be. This is to say, let's say someone who's 60 has arthritis just because they're 60 and their age-appropriate changes for age 60. Does that mean someone who's, let's say, who has lupus, who's 60 years old, necessarily going to have more arthritis? They don't have to. Lupus arthritis onto itself is an entirely unique entity, where a person has arthritis because of lupus. But as I'm sure you know, lupus is, again, not to make a correlation exactly, but like syphilis is known as the big faker, which is to say it can present in a myriad of different fashions wherein it's very hard to really know why the person has whatever they're presenting for until you start going into the investigations and then discover, whoa, okay, this person has lupus. I can't believe they presented in such a manner. Just to make make an aside, I also take care of MS patients. And when I do attend them, I'm very compelled to know, how did you come, because it's such a nebulous diagnosis. Often there's a big lead time loss until it's finally diagnosed, and often, for example, the most common thing is a person will complain of optic neuritis. That's one hallmark classic first symptoms of MS. But you know, a lot of patients I've attended to, they didn't present that way. They just felt tired or they had something else. And then through a whole host of investigations finally arrived at that point. Again, this is to say lupus patients can present in such a complex manner, sometimes very straightforward, but in the instances where the diagnosis is not known for some time, until appropriate blood testing is done to really isolate it. You may go some period of time without even knowing. And that becomes a challenge in a context like this, because a person, let's say their first presentation is lupus arthritis. Well, if someone presented me with arthritis, I wouldn't automatically think they have lupus. It would be my first thing that strikes to me, because arthritis is such a common ailment unto itself. I know one of your questions in there also related to rheumatoid arthritis and how it differentiates itself from that. And I was waiting for this because I think this is an important point. They have such similarities. In clinical presentation, they have bilateral presentation. They can be symmetric bilaterally, that is to say, they can be the same joints in both hands. So a person may present with lupus arthritis and everything seems to be on the lines of a rheumatoid patient until you start doing the testing and none of the blood testing is consistent with rheumatoid, but then suddenly you say, well, I can't explain this, and maybe you do some testing for lupus and now you have this diagnosis of lupus that happened to present first with arthritis. But not all lupus patients present with arthritis first. They may present however they present. By the way, a correlation also I'd make that there's one difference between rheumatoid arthritis and lupus arthritis, although they may look clinically very similar. Rheumatoid arthritis tends to have erosive features to it. Lupus arthritis tends not to. That's something which radiographically you can see when you do x-rays and stuff. Not to say they can't, but they don't. From a hallmark or more common standpoint of arthritis and lupus, it isn't usually where you see a lot of erosion. But in rheumatoid arthritis you may, or you would more likely.
Is lupus arthritis, is that common?
Well, it's a relative term, common. I'm not certain to say what the frequency of it is. I don't think I can I'd probably defer that question. I'm sorry, I don't think I have a great answer for that.
Oh, don't worry about it.
Yeah. I mean, it may
we can find the answers eventually.
Right, yeah, sure. And then, by the way, I'm one of those doctors who encourages, I don't know if you know, there was a study which came out and found that doctors should encourage patients actually to Google their symptoms and things, although, you know, there's always a person who may be taken astray, but patients come pretty close. In fact, I always encourage my patients in my practice, go ahead, look, Google your symptoms, Google what you're concerned about. They come about 70-80% of the way close. They don't all the way get there, but you can do a lot of good for yourself by knowledge is power in this game, especially for this problem, and I think that there's a lot of good information out there, of course a lot of information which is not correct, but that's where we come in to help refine that and give a granular zeroing in on what's being looked for and speaking to it as it relates to caring for patients with these disorders. So sure.
So we covered the steroids.